Welcome to the Healing Guardian channel. We are going to discuss the basics of research in public health, research methods in public health, a guide for practitioners. We are going to go through the whole process of research, providing everything you basically need to conduct a practical research in public health. We are going to look at how to make focused research questions, and making a research proposal, research ethics, and the role of the institutional, choosing an appropriate study design, defining your study population, developing a sampling strategy, selecting or creating reliable and valid measures, basics of data analysis and interpretation, structuring a scientific paper to share your findings. So you're going to go through the research process in its order, looking at its flow in a cyclic form, looking at basically everything you need to understand research. We have organized the work in 10 parts. Part 1 lays the foundation of public health research, understanding the foundational concepts. To start with the power of research or the relevance of research, public health is shifting from a treatment paradigm to a prevention paradigm because it is being emphasized that prevention is better than cure, and it is simpler and less costly. Rigorous research is essential to refine and improve public health practice. It is due to the results from research that are used to inform policies and designing interventions. So in this video and this course, we are going to understand the skills that you need to understand research. Besides making research, understanding other people's research requires research skills, how to conduct your own high quality research starting from scratch to the end, making conclusions and inferences, and how to successfully complete your thesis or a capstone project. And there are many other practical importances of research, talking of advancing knowledge. More research brings new knowledge, solving problems, and that is the main aim of research. Using a typical example of Ebola, in the cases of Ebola, prevention did greater in stopping the spread of the disease more than cure. If you talk of evaluating whether the vaccine was efficient, if you talk of the methods they used to trace the contacts of Ebola, the safe burial practices, it is what stopped the pandemic. So in public health, research is a basic foundation to enable health of communities. We need to understand that research follows a circular model. Research and practice are not separate but interdependent. First of all, to make research, we use practice-based evidence. These are real world clinical or community work leads you to research questions. If it is a clinician in a hospital, they can notice an unusual occurrence. Maybe there are many people presenting with dehydration from frequent diarrhea. This is a practice-based evidence that is going to prompt you to make research. So practice provides the basis for making research. Then the research will ensure evidence-based practice because the research findings are applied back to improve the real-world practice. And that is how research works. It is a continuous cycle. The researchers, whether it is in the university or research institutes or non-government organizations, they use practice-based evidence to get findings. These findings can be directed to the policymakers like the government or ministry, which will make policies, which the implementers like local government, the private sector, and community will follow. So it is always a cyclic process from the researchers to the practitioners, from the practitioners to the researchers. What does evidence practice mean? At evidence practice, we are talking of making practice or interventions based on evidence, and this evidence we get it from research. So evidence practice is an integration of three ideas. First of all, it is based on research evidence. For example, if you wanted to promote vaccination against cervical cancer, maybe using HPV vaccine, a health worker will need to get best research evidence. The findings may be global studies that are showing that the vaccine prevents cancer. He needs it to inform his practice. Number two, he needs clinical expertise. That is his experience in administering vaccines and talking to people. That is expertise to the size of the clinician. But you also need to value the patient, to consider patients' values and preferences. Usually, patients are concerned about accessibility, about the safety of the intervention. Meaning, to make evidence-based practice in public health, we use all the three are important. You solicit the values or you consider the preferences of the community. You look at the expertise of the clinicians, but also most importantly, you should base on research evidence, making research very important. Research shapes policies in public health. Well-conducted research provides the objective evidence needed to convince policymakers to act. It can demonstrate the scale of a problem. For example, how many people are infected. You find they have published a research finding that it has been discovered the prevalence of HIV in Mbarara is now at 41%. So you are looking, it demonstrates the scale of a problem. It is not the same as simply knowing that HIV rates are high, and all these are used in practice. Research can be used to test if which interventions are most effective. You research about the available interventions and you assess their effectiveness. That is how research shapes policies. For example, if you make an initial research on the high number of motorcycle accidents in Kampala or head injuries, on the data for the government to create mandatory helmet laws, that since there are very many people dying from head injuries among the border men, over prevalence of 50%, maybe 2 out of 10 border men have got head injuries, that will force the policymakers to make new policies. So the aim of research in public health is to shape policies which will affect the practice itself. The fields of public health, there are many, but the fundamental ones we talk of epidemiology. To note that in public health, we are looking at the health of a community at large, not focusing at individuals. In epidemiology, as a branch of public health, we are studying patterns, causes, and effects of health and diseases. Like you are tracking a cholera outbreak in a village, that is epidemiology in public health. We also do public health management through designing, running healthcare systems efficiently. Maybe for the case of, you have heard of that, we have issues of water contamination or diarrhea or dehydration. Then you assess or you ensure that the local clinics have enough oral hydrate. Do they have enough ORS? There we are doing public health management. In public health policy, we are creating laws and regulations to protect the public's health. For example, if the district, through information, maybe through the district health officer, they can pass a bylaw requiring safe water sources. That is all part of public health. And last, we can talk of health promotion, whether using social or behavioral sciences to prevent disease. You may solicit or you use the village health team, the VHTs, to teach families about hand washing. There we are using behavior sciences to prevent disease. So those are some of the fields under public health. So the big picture, to summarize the introduction we have had, is that research and practice are dependent. Research informs practice. But also what we research about, the gaps we aim to fill using research, we get them from practice. That is why I say that practice should be evidence-based But also, research should be practice based, they are interdependent. The evidence based practice combines research, expertise, and patient values. That's what we have looked at. There are three ideas that intersect. We need research. The clinicians should be should have the necessary skills. And number three, the values and preferences of the patients should be considered when making interventions. We have said research is a powerful tool to inform and create effective public health policies, and many times they publish this research whether through journals, even through media. You find they put information throughout media, mass media, showing prevalence of this. It has been discovered. And many times when they are published, it is a way of forcing the government to act. So your work as a future researcher has a potential to save lives on a large scale. All the research you make should be published in order to inform the policy makers. Number two, understanding the importance and basis of research. Part two is about how do you frame a research question? How do we come up with a research question in the first place? Because it is the basis of the research. So we are going to go through the process of making a research question, which will lead us into how to make a research proposal. How do we make research questions? When you are framing a research question, everything in your research project depends on having a strong focused research question. Meaning, a research question is the basis of everything you will do in the study. Meaning, when the research question is vague, the research wholesomely will be vague. A good question guides your literature review. What will you read? What do you need to research? Which gaps do you need to identify? They come from the research question. It will also determine the study designs we'll use, and it will also determine the data analysis you'll do at the end of the research. So the research question is the most critical step in the research process. One of the important things that you don't need to reinvent. That is, if you have already got the idea, maybe if you have already looked at the thing you want to study, that instead of saying on the part of research question, instead of saying I want to study malaria, a good research question which will guide you throughout your research should be compound and good enough that instead of saying I want to study malaria, you may say that what is the relationship between bednet ownership and incidence of malaria among children living in Gulu district. So the research question determines the ethical concerns that will come about. It will determine which type of design you need. If you are looking at relationship, it will determine even the data analysis you do. But even in the process of preparing your research question and your research proposal, a literature review is important. A literature review is a systematic search to find out what is already known about your topic. You first find out what is already known because in ethics, we believe if you make a research which is not relevant, it is unethical. Already you want to look at malaria in Gulu district. There are already many researches that have been done about malaria in Gulu district. So you need to read already the available articles to find the gap that your research is going to fill. So the purpose of the literature review is to find the gap, what is not yet known, and this gap is where your research will make its contribution in a simple way. If you already have a good old car in the garage which is already good enough to do the job, there is no need for buying a new car, and that is the aim of making a literature review. How do you find gaps systematically? Because that will be the question. You are doing literature review. How do you do the literature review in order to identify the gaps systematically? So this is beyond just Googling or searching about the idea. The first thing in what you are looking at, identify the keywords. If you are looking at HIV and border men in Kampala, you think of the keywords or search terms that you can use to look for related articles. For example, you may search about motorcycle taxi. That is a keyword because you are looking at border men, because it will bring to you articles in relation to that. You may use keywords like transactional sex because you are looking at HIV. You may use keywords like condom use. So these keywords, they guide you in which literature you are going to review. Number two, use academic databases like PubMed, Google Scholar, because they are rich with many research papers. And number three, you look at the limitations or the future research sections of existing articles. Many times in the discussion section of a research paper, it is like a treasure map to new research questions. When a previous research was done, during the discussion, there are always those gaps they try to bring out, or it prompts you to research. There are those research ideas. So you look at the limitations of other articles, or their future research sections, or their recommendations. Then they can guide you in looking for the gaps to fill in your research. So framing questions can be done in 4 steps. When you're framing your research question, you have identified the topic you want to deal with, you have done a literature review, and you have got the gap you want to fill. Now you say, how am I going to frame my research question? The first thing, it should be in form of a question, not a sentence. For example, you can say, what is the relationship between X and Y? If you use the other example of VHTs, if you have village health teams, maybe they are moving around in the village sensitizing about vaccination or about public health practices. You may say, what is the relationship between VHT home visits and child vaccination status? That is the first part. You first frame it as a question. It guides you that I'm looking at relationship, not an ambiguous question. Number two, you define the population. Among whom are you going to determine this? That I'm going to study relationship between VHT and child vaccination status among mothers with children under 12 months in Gulu district. You have added the population to your research question. So your research question in Wholesome should identify the outcome of interest. If we read your research question, can we get what outcomes we expect from your research? What are you trying to measure? So in that research question we have tried to frame, we are showing that we are measuring are children receiving all scheduled immunizations, because you are looking at relationship between VHT home visits and child vaccination status among mothers with children under 12 months in Gulu district. It shows you your outcome of interest. Then you all have to also add a time frame, because researches, usually those which are not longitudinal, are done at a specific time. So you have to say that as measured in one time survey in 2025, as measured in a one time survey in July 2025. There it is, Wholesome. So in brief, your research question should focus on one research issue. Every research question, one research issue. That this one I'm looking at relationship. Don't mix that relationship and association. Every research question, one research issue. They should contain specific and narrowed ideas. Instead of saying among mothers, specify which mothers. Should be researchable, should be feasible, should be original and authentic, should be relevant to your study field, and should offer an adequate scope for analysis. So in summary, we use our short form POT, that you should look at your research question. Does it have the population? That is P. Does it show my outcome of interest? That is O. Then does it show my time frame? So that is POT, population, outcome, and time frame. So you by the time you're getting your research question, you have identified the gaps that there is no research that has filled this gap, and you will use this in your research proposal to convince people, either the ethical committee or the funders, because your research should be filling a certain gap. When doing research, there are two types of research. We may do a primary research or a secondary research. But in a secondary research, basically we are using existing data. You don't hassle to look for data. You use data that was collected by someone else for a different purpose. It is often faster and cheaper than collecting your own data. It is appropriate when an existing data set contains the variables you need to answer your research question, that already what you are looking for is available. Why are you looking for another set of data? An example, if you want to look at maybe nutrition status among Ugandans, or you are going to look if you want to look at domestic violence or family planning in Uganda, yet there is already a survey that has already been done by the government through the UBOS. Maybe they have already made a consensus, a national consensus. A lot of data is available in that consensus. So if what you are looking for has already been collected, then there is no need to waste resources. You do a secondary research. You just have to make sure that in your research you show that where you got that data, it is authentic. You look at the methods they used, how reliable is the data. Those are the things you have to ensure to put in your research to show that the data you used is reliable. So that is a secondary research. It is often faster and cheaper. But the primary research is there. The primary research, you have to go out, you collect the data you need, then you do the analysis. Ethical standards and practice. After you have got the research question, you know now what you need to do. The next question comes: what are the ethical considerations? Public health research will deal with people. Most of the public health research is on people, not animals. So ethics is a primary rule to protect people from harm. Ethical conduct is not just about rules. It is the foundation of the trust that communities place in research. Understanding ethics is not optional, it is a requirement for any research involving human participants. So your most important research tool is not just a survey or lab test, but it is the trust of your participants. And many times people refuse to participate in research due to betrayed trust in the past. Maybe their data was handled poorly, they were exposed, fear of being exposed. That comes due to unethical actions among the researchers. So ethics is important, and this is seen from the past history. What brought up making the institutional review boards, making the ethical codes. Modern research ethics were born from past tragedies where researchers exploited vulnerable people. For example, the Tuskegee syphilis study, where they were trying to study the natural history of syphilis, but they did it on vulnerable people. First of all, they were illiterate and they were Negroes, they were Black Americans in Alabama. And they carried out that research for over 40 years, where they first of all, they didn't get their informed consent. They got people with syphilis and their controls. Then those who had syphilis, they were fooled or deceived that they are being treated, yet they were not being treated, in order to see the natural history of syphilis. So after some time, over 40 years, they did these experiments without their consent, they were not free to move out of the project. And when it spilled, that is when making institutional review boards was legitimized, that all research has to undergo approval. So this is the history. That is why research has to be modulated. So the review boards themselves, they are not barriers, but they have to make sure that the work is ethical in order to maintain trust. There are three core principles of ethics. Core ethical principles. Number one is autonomy. You have to respect the participants and they should make informed decisions about participating. Beneficence, you have to do good and maximize possible benefits. People should benefit from the research. And number three is justice. The research should be fair. Dealing first of all with who are you interviewing, who are you doing the experiments on. Are you simply choosing vulnerable people? Were the participants chosen fairly? So those are the main. There are many other. But first of all is autonomy. Did the participants decide to participate? Were they fully informed about the risks and so on? So those are the main three. And how does autonomy work in practice? One of the gold standards of autonomy is informed consent. And it is a process. You have to clearly explain in a language that a person understands. You have gone out to pick research participants. Even before you give them the questionnaire, explain to them what they are going to do and in the way they understand it. You tell them the purpose of the study. You tell them the risks and benefits of participating. That is for experimental studies. Then participation should be completely voluntary, no coercion. They have to be able to quit anytime without penalty, and their information should be kept confidentially. That is what autonomy means. People should have control over their own body participation into that research. Justice in practice means fair selection. This demands for sound and scientific reason for choosing your study population. And these are the things that are asked during ethical review. Is there autonomy when you are choosing the participants? Number two, will there be just or fair selection of the participants? Because it is unethical to select a population like poor villagers, or you go to students simply because they are easy to access or less able to say no. So the group that bears the risks of the research should also be able to benefit from its results. If you have carried out your testing a drug, the participants or that village where you did this intervention, this test, they should be among those who will receive that drug at accessible prices or even free of charge. That is what beneficence emphasizes. So you don't choose participants because it is easy. Dealing with children, there are many ethical issues. There should be informed consent and assent. Number two, you have made a research question, you have got your research question, you have looked through the ethical considerations. Then, before any research begins, you have to make a research proposal. And a research proposal is your study's master plan. How to make a research proposal. A research proposal is a clear, concise, and persuasive document that outlines your proposed research project, meaning you still have it in plans. It has to be clear, concise, and persuasive. Talking about persuasiveness, it cannot be persuasive if it is not relevant. Meaning, mainly the literature review is the one that shows the importance of the project you are promoting. You want to do that research. Is it beneficial? Meaning, the better the literature review, and you identify that the gap is really important, then it becomes persuasive enough. There are mainly three functions of making of your research proposal. First of all is securing approval, because you have to get permission from the ethics committee, whether at the institutional level or national level. You have to obtain funding even beyond this common research. These big research projects, you have to get funding, and it is your research proposal that has to do the magic. And number three, your research proposal will be your roadmap, how you will conduct the research. So a lot of care has to be done. A proposal is like your promise to the world, or you are sending your proposal to this committee. Like, it proves that you have a clear plan and you are ready to conduct serious ethical research, meaning it has to be standard, and clear. There are many formats, but these are the main components of a research proposal. Of course, you cannot make any document without a title. It has to be short, descriptive, and engaging. Many times when these proposals are presented in documents, by the time someone picks interest to read the whole of your research proposal, your title should be captivating, should be descriptive of what you are going to do, and should be brief. Then number two, which is one of the most important, is the introduction and background. This is where you talk of the abstracts and those preliminary sections, the table of contents. In the abstract, even before I read your 15-page research proposal, I will first read the abstract, which is like your executive summary of everything, of the whole of your research project. Meaning I'll first read the abstract, which may be maybe on one page or two, and I says, does it have substance? Meaning your abstract should be perfect enough to make people pick interest to follow through the rest of the proposal. You have to state the problem statement. So the introduction and background is like the why of the study. Is the study relevant? What do we benefit from the study you want to do? What solutions does it make? So it is like a background. You provide a background showing the relevance of your research. Then you state the problem statement and research question, which are like the aims. What gaps? You have convinced us about the background, the relevance. Okay, there is a lot of prevalence. Now there is research gaps. You need to state the problem statement. What are you solving? What are you trying to research for? Your research questions should show the gaps you are going to fill. That is why I say that every research question should have one research issue. Then people need to know the methodology. How are you going to do what you are claiming to do? So if it is a fund, I will say that how will you do it? You have convinced me about the why, but to find you, we need to know how perfectly will you do it. So you present your study design. You present your study design, the population you work on, everything you present, you have to verify it. You have to you justify everything. With the sampling, you justify the methods you use. The data collection, you justify the methods you use. And how will you analyze the data you have collected and the recommendations. Then also the ethical considerations. In your research, have you considered the ethical issues that may come up? How will you protect your participants? And lastly is the timeline and budget. You have to prove that your project is realistic and feasible, meaning you state the timeline in which you will do every activity and you put your budget. You put your budget, how you will, what it requires. Because if you are going to receive funding, many times if it is very expensive, yet we are gaining little, it can also be considered unethical. So for a study link, if we are linking household water resources and cholera outbreaks in Kampala or around Gulu, your methodology, in the part of methodology, you have to put a detail. How will you test the water? Which methods will you use? What is your budget? That I will be using a border man for 40 days. Every day will be using 20,000. So I need 800,000. You put it in the budget. So a research proposal in summary is like you are telling the whole story of your research, starting from introduction even to how you will plan to disseminate the findings you have got. So the foundation of making a research proposal is a powerful introduction. Your introduction must grab the reader's attention and convince them that your research is important. Structure of the introduction, you start broad. You introduce the major public health problem you want to solve. That you say that in northern Uganda, there are high rates of post-traumatic stress disorders due to the past conflicts. There was LRA insurgencies and so on. After presenting the problem, you narrow it down. Now, which gaps are you going to feel? Okay, it is known, yes, the post-traumatic stress disorders are there. If you're doing on HIV, yes, it is known that HIV prevalence is there, it is high, it is at 50%. And there are already many researches that have been done. Then you justify your research by narrowing down using the literature review that you made so that you clearly state the gap in knowledge. Which gap in knowledge do you want to fill up? So in the case of the post-traumatic stress disorders, you can say that little is known about the coping mechanisms of the natives or how the traditional coping mechanisms affect symptoms of post-traumatic disorders among university students. There are many other researches that may have been done about prevalence, but you may not find a research that was dealing that how do people use coping strategies, maybe like traditional storytelling, engaging in culture activities, how do they affect their symptoms, and specifically in school going students or children. There meaning you made a literature review and and you found out that that gap was not yet filled. After narrowing down and stating the gap, then you state your purpose, because your purpose has to fill the gap. You clearly and precisely state the aim of your study and the research questions that you will answer to fill that gap. So you can say my aim to investigate the relationship between engaging in traditional coping mechanisms and post-traumatic stress disorders among students at Gulu University. So that is the introduction. It provides the basis for the proposal. Then you go to the methodology, which is like the engine room. We consider the methods and ethics. You have convinced us about the need, about the why. Now we need to know how are you going to do it. So it is a very critical section because it will determine whether you need to be funded, whether you need to be given a go ahead or not, even if what you want to research is important. Starting with the study design, will you use cross-section? Will you use cohort? Will you use qualitative research? And why did you choose that one? And I'm going to use a cohort because I need to follow up to find the incidence. Whatever. You have to tell the study population and sampling what are you studying and how will you select the people, who are you studying, which population will you use, and necessarily why that population. So everything has to be defended. The data collection, what tools will you use to collect the information? How will you administer them? How do you analyze that data to make conclusions? Then which ethical considerations will you use? That I'll use informed consent, I'll be confidential, I'll protect the data. So your aim, you are convincing the ethics committee or you are convincing the funders to give you the resources. Then when you're finishing your research proposal, you have to state the budget. List every single expected cost. You talk about the timeline, a realistic schedule of your for every phase of the research. Then your plan for dissemination. How would you inform the community, the district health officer, or the participants? That I will write a letter to I will make a report to the district health officer after the research, or I will make a simple summary for the local people or for my participants or for the village to inform maybe to the village, to the local council leaders and so on. So in brief, you have to talk about everything you will do in your research. And it has to be persuasive, clear, and concise. That is the research proposal. The research gatekeeper. This is what we have been talking about. Who protects the participants? You are presenting this research proposal to the institutional review board, which is an ethics committee that reviews research proposal before the research begins. They have to look at the ethics. Is it ethical? In Uganda, this is often the Uganda National Council for Science and Technology. But at lower levels, it can be the local institutional review boards at the university or the hospitals. The aim of the institutional review board is to ensure that the rights and welfare of the human subjects are protected. So after your research proposal, you have to defend it. And the board can make 3 reviews. They may either exempt, the types are either exempt, expedited, or full committee review. And these depend on the risk of your research. The level of IRB review depends on the level of the risk to participants. In the exempt, it is done for research with virtually no risk. For example, if you are analyzing data that already exists, that I'm going to use data that was made by the UBOS, or I'm going to use national consensus data to make my conclusions. That one is an exempt case. So it is just reviewed, maybe the chair and a designee or a staff, they can review such a proposal. But it can be expedited. That is for research with minimal risk or no more than what is encountered in daily life. If your research is going to be a simple survey from their people, or it is going about blood draw, you are going to maybe to use blood from people, that is a normal encounter in daily life. Of course there is risk, but at that level it is called expedited. So it is reviewed by the RIB chair or a designee. But there is a full committee review, or it can be called a full board review. This one is done for research which is more than minimal risk. If you are going to study testing a new intervention among people, that there is high risk. Therefore, it has to be reviewed by the whole board, by the whole institutional review board. So those are the 3 levels of the review. Another ethical issue that it is always looked at in the review of research proposals is the protection of the data and the people. Your research has to do no harm. So that is the key part of protecting confidentiality. There have to be anonymity, that no one, not even the researcher, can link the data to a specific person. You collected that data in a way that not even you can identify the people to which those data sets belong. That can be done using online platforms. But there is cases where you cannot, where you the researcher but you have to be confidential. So the researcher can link the data but promises to keep the link private and secure. So the methods we use for protecting people and data. Number one is using ID numbers instead of names on surveys. Instead of writing people's names, you can use their ID numbers. You store the signed consent forms separately from studied data, because the signed consent forms, they include the details of the people. So you keep them separate from the data you collected for confidentiality. Password protecting and encrypting computer files. That is if your data is in digital format. So the aim of storing the data is protecting the people. Without confidentiality, the research is unethical. Because if you are dealing with HIV patients, disclosing people's data, or if it is found out and they are identified, can cause stigma, isolation, trauma. So people have to be protected. When you go out to make research in public health, there is a type of research called a community-based participatory research, that is CBPR, and it is different from the traditional research. Here, you, the researcher, you have to partner with the community. The community members are involved as equal partners in all phases of your research, starting from developing the research question to sharing the results. So here you involve the population of study, you involve them in the process, not looking at them as subjects. So it can be that you go to the community. If you are doing a study to reduce malnutrition in Karamoja, you go to the community, you first talk with the village leaders, you talk with the mothers, the VHTs, and you ask them what they see as the main barriers to good nutrition. And then you design a program together, meaning you have involved them in your research. You go to them, they tell you the problem, then they suggest the research questions, things that need to be researched about. Then you start the process together, meaning even when you are getting research assistants, you get them from that community. The traditional research, you just observe people as subjects and you make observations. The power of using that CBPR is that it is better and more sustained. It leads to more sustainable health outcomes. The results of that research can easily be taken up by that community that you have worked with. It recognizes the community as a unit of identity, and that enables them to, like, it puts the trust in the research you are doing. Even when you are collecting information, chances are high of giving you authentic information. It builds on the community strengths and resources, because you can easily tap on the community. Since you are working as a community, they enforce it, and you use the available resources, you use the available people, you use their technical people to help you in the research. Facilitates collaborative partnership. It promotes co-learning and capacity building. When you're doing that research, you get these people, you train them, you give them skills, you sensitize them about how you'll do the research. In all the research process, you're doing capacity building, and also ensures that the results are shared with all partners. Even the outcomes of the research will be easily taken up by that community. So instead of doing traditional researches in public health, it is better you involve the community. In this research, there's also what they call coalition building. You're going to make a research in this community. You build a coalition, which involves identifying and bringing together all the diverse stakeholders who have a shared interest in the issue you are looking at. So it is like if you're going to research about HIV among border men in Kampala. Okay, let's talk about alcoholism among border men. The youth leaders may be interested in that research. The district police commander may be interested. The heads of hospitals, or if you talk of district health officers, you talk of local council members, national government organizations, there are those who will be interested in such a finding. So in coalition building, you involve them during the research process. In this case, they can support you, they can advise you, they can even simplify the work for you. That is what they call coalition building, and it makes the research a lot easier. You involve those who are interested in what you are looking at, those who will be concerned. Part 3. So we have looked at the introduction. I've looked at the introduction, making research proposals, doing the reviews, the types of research you can do, the community-based research. Now we go to the collection of data. That is, your research proposal has been approved. Now we go to the process. There are two types of research in data collection. There is qualitative research and quantitative research. And those are the ones we are going to go through. Quantitative research is the one that looks at the why and how. Quantitative research measures what, where, and when, but qualitative research explores the why and how. In qualitative research, we seek deep understanding of experience, perspectives, and contexts. It uses words, stories, and observations. You are not collecting data as numerical values, but you go to people, you collect their stories, their words, their perspectives. So it is like you are understanding how do people make sense of their world. That is what qualitative researches are about. If you have a quantitative research, a quantitative will look at figures, that the prevalence, maybe that the rates at which the women are using family planning or contraceptives is 40%. That is quantitative. But qualitative, we need to know more. You need to add more flesh. That someone may go and you make interviews, you make focus group discussions, you interview the women, and they tell you their reasons why. There you are making qualitative researches. So also one of the research gaps can be we can have numerical quantitative researches, but when the qualitative research about that same topic is lacking. So you can interview the women. They tell you why do they feel, why don't they use the contraceptives? Why aren't they going for screening? Then they may tell you they fear the side effects they have heard from friends, or they are worried that their husbands will not approve. So all these you are getting the why and how. That is the aim of qualitative researches. And qualitative researches have different approaches from quantitative ones. In a qualitative research, there are mainly three approaches. There's what they call a grounded theory, which aims to develop a new theory that is grounded in the data from the field. So you start with no preconceived theory. You are trying to establish a new theory. An example is you are studying how communities in Gulu are dealing with a post-conflict trauma, maybe from the war, in order to develop a new model of resilience. You are studying how they cope up in order to develop a new model of resilience. So you are building up a new theory that is grounded in the data from your field. But in ethnography, which is common, it is deep long-term immersion in a culture or community to understand it from the inside out. The researcher becomes a participant observer. You go and you live with the people. You go, if you're looking at HIV risk around the lake shores of Lake Victoria, you go and you stay with those people for a long period of time. You go on recording data, observing them, recording, interviewing them, making qualitative, meaning you are using words, stories, they are narrating, you get focus groups. So you go and you live in a fishing village on Lake Victoria to understand the social dynamics that might be influencing the HIV risk. Is it their perceptions? Is it because they are poor? So you are not just looking at quantitative data, the prevalence of HIV at Lake Victoria, but you are using ethnography as an approach of qualitative research. And the last one is case study. This is not the same as case control. In case studies, you get those who are affected or the areas of interest. Then you do an in-depth investigation. So you can do an in-depth investigation of only one clinic or one event or one person to understand a phenomenon in its real life context. Either you get the people who are affected, then you do an in-depth investigation to get the ideas surrounding it. You go and you do an in-depth study, maybe around Tasso, a Tasso clinic in Guru, so that you understand its success. Is it successful or not? So that is what you call case study in qualitative research. When you're doing qualitative research, we are gathering qualitative data. There are many methods. You can do in-depth interviews, that is one-on-one. One-on-one interview, you get maybe a traditional birth attendant, then you want to understand her role in the community. You go to her, talk to her, then you start an in-depth interview. You can use semi-structured interviews where you have a guide with topics, but you are free to explore new ideas. If what they have said sparks you to speak about something else, so it is semi-structured. It's just like a guideline. Or you can use focus group discussions where I do a guided discussion with a small group of people, like 6 to 10 people, to explore their shared and differing views on that topic. But the interaction between participants is key, because focus groups can easily go off track. And focus group discussions are used on things which people have in common. You cannot use them on issues which are very sensitive. But you can do a focus group discussion on, you get a group of young men, you want to understand their views on masculinity, or what does it mean to be a man, or about seeking health care, their views. You can get like 6 of them, then you start You start interacting with them, they start bringing their differing views, they discuss, then you make a report. So in qualitative data, you use an interview for personal stories, you use a focus group for looking at social norms or group dynamics. That is how we collect qualitative data. But you can also collect qualitative data by observation. This involves watching and recording behaviors, interactions, and events in their natural setting. There is some data where you cannot rely on what people have said, where people easily get biased if you're asking them sensitive information. For example, if you're asking, anyway, it may not be applicable, but you're asking how many times do you bathe a day, or how many times do you brush your teeth a day. That data may not be reliable if you're interviewing people, but there is data where you need to observe and see for yourself and you make conclusions qualitatively. So it helps you to understand what people do, not just what they say they do. You as a researcher, you can be a non-participant where you are watching from a distance, or a participant observer where you are taking part in that activity. If you want to see, do people wash their hands after toilet, you go and you get an observer, or you educate an observer, research assistant, you put them in a strategic position. They count how many people have come from the toilet and how many have washed their hands. There you are doing observation. So people may tell you that, yes, I feed on a balanced diet, I eat, I drink milk, I do this. But it is better if you have to see what people do. You look at how many people are eating vegetables, how many people are taking sodas, how many sodas do they take. There you are doing observation. So you do it with cases where people's views cannot be relied upon. And the issue that comes in qualitative research is, how do you analyze it? You imagine you have interviewed someone for 1 hour, they have been speaking, you are writing, or they have filled questionnaires where they are using statements. The interpretation is what we call qualitative analysis. So it is an interactive process of identifying patterns and themes in your text or observation data. The key steps: you first organize that data. You transcribe the interviews and you type up the field notes. You have to collect that data. If it was a focus group discussion or you didn't have time to write, immediately after it, you write down, you note down what has been collected. So you first start with organizing it, type up the field notes you collected, organize them, then you develop a code book. You create a list of codes or labels for the key ideas that appear in that data. For example, you may put codes like, coding is like organizing your clothes. You put all the shirts in one pile and all the trousers in another so you can see what you have. So coding is like labeling the key ideas. If people someone presented you their interview, they mentioned many things, then you read, maybe you are looking at issues that women face in accessing health at this facility. Then you look at the keywords in that essay, in what they were saying, the transport cost, then you put it as a label in your analysis. My husband I need to seek husband's permission, that is another label. The attitude of nurses discourages us, you put it as another label. So you pick out those key ideas in the statements which you can use to interpret. Then you may look at how many people have mentioned this issue among the 200 women I've interviewed. 198 said that the transport costs are high. So there you're using qualitative data, but to interpret it, you need to translate it into figures. That is why we need coding. So in the coding process, you read through the data while you are applying the codes. Then you group the codes into themes and interpret what they mean to answer your research question. So that is how we do the analysis of qualitative data. You have collected it, First, get the codes you are going to use. Look for the labels in that qualitative data. Then notice these codes often appear together or in certain areas. Then you group them into a large theme. Maybe you do in your analysis, you say that barriers to access to health services. Then you outline what they have been saying. There you are analyzing words or stories. Observational research designs. So we have started with a qualitative, but now we come to the quantitative research where we are looking for numeric, we are using, our data is recorded as numerical values. We may use observational or experimental designs. Observational or experimental designs in order to analyze your study population. If we start with the observational research designs, in observational research, the investigator does not manipulate any variables or assign participants to groups. You simply have to observe. You don't manipulate what is happening. You just look at it in its natural context. You are looking between smoking and lung cancer. Don't manipulate. Simply observe and make conclusions. So all study designs where we are just observing, they are called observation. These designs are crucial for understanding the extent of a problem and for identifying associations. They answer the questions like who gets sick and what factors are related to their sickness. We mainly use observation. We are not testing interventions, but in observational designs, we are identifying risk factors. We are relating, we are identifying association in brief. The observational research may be cross-sectional. That is where you are getting just a snapshot throughout the whole population. You are looking at cause and effect at the same time. Or it can be longitudinal, where you are either going back in time or you are going forward in time. So you don't have to alter. You don't have to alter your population or your I variables you are studying. There are mainly three observational designs: the cross-sectional, the cohort, and the case control. The cross-section is the most common design in public health research. Data on both the exposures and the outcome is collected at the same single point in time. You just go out in the population, either you're using surveys or you're using forms, you record information, you study the exposure and outcome at the same time. That do you smoke? Are you coughing? Or do you smoke? Do you have lung cancer? You're looking all of them at once. So it gives you a snapshot of that population's health and behaviors at that moment. You assess the risk factors and the outcome at the same time in your research. You may be looking at many risk factors and many outcomes, but you are studying them at the same time. It is fast and inexpensive. That is why it is most common. Yes, we deal with cheap things, and it is good for measuring prevalence, because you go and you measure at one point of time that in July this is the prevalence, because you went and measured exposure and outcome at the same time. So that's why it is compared to a snapshot. But the cohort, especially the prospective cohort, is longitudinal. Cohort studies can be longitudinal, may be prospective or retrospective. But all of them, as long as it is a cohort study, you begin with exposures, not outcomes. You begin with exposures, not outcomes, even if it is retrospective. For example, you go to a certain, if you are looking at lung cancer in people who are working in a certain industry, you go and you assess those who were exposed maybe to asbestos and those who were not back in time. Then you go and you follow the records that were recorded later on, how many developed lung cancer. It is not like case control, you're not getting flashbacks, but you go in the past records and they have to be reliable. That is the restriction of retrospective cohort. You go, you get data that these are the people who were working in this industry. They were all exposed to asbestos. These people worked in another industry, they were not. Then you go and you look for the records after that exposure, how many developed lung cancer. So it is a retrospective cohort, but still it looks like a prospective. But in case control, and we will look at that. In case control, you start with the outcomes. You have lung cancer, you don't have. Case control, you can even use records, past records. You go to the past, you look for the records. Were they exposed to asbestos? Were they exposed to smoking? Even if you're using records, it can be case control. So it only becomes retrospective. You are both using previous data to assess the exposure and outcome, but the exposure must have preceded the outcome. That is for cohort. Exposure has to precede the outcome. So the most common and ideal is the prospective cohort. In this design, you follow a group of people who are initially free of the disease forward in time. Then you measure their exposures at the beginning. You follow them, then you see who will develop the outcome, what we call incidence. Because you measure exposure before the outcome, this design is much stronger for suggesting a cause and effect relationship than a cross-sectional study. Cross-sectional study, you cannot know whether the cause and effect at what time they happened. You are simply measuring them at the same point in time. So among the observation studies, the prospective cohort is the most ideal for cause and effect relationship. Then the flashback, which is a case control design. This design is retrospective, it looks backward in time. You start by recruiting two groups, the cases and the controls. So if you're investigating a certain rare cancer, you get 50 children who have that cancer and 50 children without the cancer. You start with cases and controls. Then you assess in the past. Maybe you interview their mothers. Then to look back and compare the past exposures. You may say that was this child, did she get malaria before? Maybe you want to relate malaria to a certain rare cancer or anything like that. So in case control, start with cases, controls, then explore their past exposures. You may either do interviews or you use records. It is very efficient for studying rare diseases, and that is when it is appropriate. Otherwise, cross-sectional and cohort studies provide more information compared to case control. Its main limitation is recall bias. So in summary, how do you choose your observational tool? If you are doing observational designs, when do you choose which tool to use? The first thing is the time factor. Do you want to assess this condition at this specific time? Meaning your research question dictates. Your research question shows whether you want to assess at that time or in the past or in the future. So if your research is going to be done longitudinally and forwards, then automatically it dictates that you need a cohort. Number two is what is happening now. That is in cross-sectional studies, one point in time. In cohort, what will happen, what we'll call incidence. In case control, what happened. So case control, you look for the cases, people were affected, then you assess what happened in the past. It also determines. Then number three, the strength. If you want to determine causation, then the cohort is the ideal. Any research, whether you are determining does this cause this, if you are using observational, cohort is ideal. Then if you want something fast and cheap, the cross-section is your option. Then the weakness says cross-sectional cannot determine causality. So if you are looking at causality and you use cross-sectional, then your data will not be taken, like your data cannot be used for determining that. That is why you say that your research question is very important, because it prevents you from wasting resources. Imagine wasting a lot of resources collecting cross-sectional data, which cannot fulfill the purpose of your research question. The cohort study is slow, expensive. The case control, the weakness is recall bias. So there is no perfect design for observation. It depends on the circumstances, on the research question, and your resources. So those are the observation study designs. Experimental research designs. These ones are the gold standards for testing interventions. And you need to know that it is not only randomized controlled trials. In public health, there are a number of experimental designs. It is the gold standard for determining if an intervention has an effect. The two features we use to say that this design is experimental. Number one, if there is manipulation. If you as a researcher, there is something you are going to do or something you are going to apply that we are going to give a certain intervention and see what will happen. We are going to provide counseling services and see if the stress cases are going to reduce. You are in an experimental design. If number two, if there is randomization, if the participants are randomly assigned to receive the intervention or not, then we call it experimental. That this district will be given the intervention, the other one will not. Then we compare. You are in an experimental design, so it doesn't need to be in a laboratory. The power of randomization is one of the reasons why experimental designs are the gold standard. In randomization, what we call random assignment, it provides equal chance of either being in the intervention group or the control group. Though, as you're going to see in a little time, that there are also some cases where you cannot randomize, but still you are doing an experimental. So if it is a randomized experimental design, every participant should have equal opportunity or probability of being in either groups. So its purpose is to make sure that the two groups are as similar as possible in all factors. Sometimes confounding factors are not known, or even if they are known, they cannot be eliminated. So what you do, since you are going to apply intervention, it has to be randomized that the people in each group, that we assume that the confounding factors have been equally distributed. They are the same in both groups, meaning whatever caused the better effect in our intervention was the intervention we used, not the confounding factors. So randomization controls for confounding. Randomization also eliminates selection bias and allows us to be much confident that any difference we see at the end of our study is due to the intervention, not some pre-existing difference between the groups. So in brief, randomization is like you are flipping a coin for every person that you come, you flip a coin. If it is head, you go to the other group, tail, you go to the other group. So confounding is controlled for, and that is the power of randomization. In experimental designs, one of the issues that come up after your research is the internal validity of your research. And what we call internal validity is how much confidence do we have that the intervention X you used and nothing else caused the change in the outcome. You were looking at the effect at drug and the blood pressure. What if there is at whatever you may not be 100% sure, but the internal validity is the measure of how much confidence. Meaning the higher the internal validity, the higher the reliability of the experimental results. Experiments with randomization have high internal validity because it controls for other confounding factors. So if you didn't randomize, if you use an experimental design without randomization, they have lower internal validity. There are mainly three common threats to internal validity in public health research. Number one is the history. Was there an external event that happened during your study that affected your outcome? Maybe the public health team organized a new dietary program and they are going to test that this new dietary program reduces blood pressure. Then after starting your study in the population, Then the government introduces a new campaign, reduce salt campaign, that we have reduced a national campaign for reducing salt put in the food. So at the end of your study, you may make results, you're saying it is our intervention, the new data program that caused it. Yet in the history of your experiment, something happened that might have caused another change. Because if they make a reduce salt campaign, reducing salt, the chances are high that it is the one that caused the blood in the drop in the blood pressure, not your intervention. So they always assess the history to see the internal validity of your experiment. Maturation, the participants naturally change over time. You're doing a cohort, maybe okay, you're doing an experimental design which you are going to observe for over 8 years. There is also probability that as people go on maturing, they change, they become wiser, they get older. That can affect the results of the outcome. And number three is testing. Many times when you take a pre-test, it influences the behavior on the post-test. You first came and you first tested people's blood pressure, then you apply an intervention. When you come to test them again, chances are that they can manipulate their behavior, because when you test them before and you come back to test them again, it influences their behavior. So it depends what you are testing, which intervention. So those are the main threats to internal validity. But as much as we can, we need to be more confident that it is our intervention that caused that outcome that we saw, not anything else. So internal validity is like the power of a test. The types of experimental designs. We start with a classic experiment, which is called a randomized controlled trial, or can be called a pre-test, post-test randomized controlled trial. The steps are known. You recruit the participants, then you give them a pre-test. If you are going to test them on a drug that reduces blood pressure, first test them before the intervention. Then random and assign them that you'll be in the intervention, you'll be in the control. But you have to ensure that there is blinding because of what we talked about internal validity, that testing can, or even people knowing what you are looking for, can influence, can bias your results. So after randomly assigning them, give them the intervention, give this group the intervention, the other one don't, or give them a fake one or a placebo. Using a placebo is another way of blinding them. They don't know what has been given to them. After some time, do a post test, that is a test after the test. Measure the outcome again. Then the effect is the difference in the change between the two groups. Then the last part will be in the data analysis that we will see at the end. That is the classic experiment for most clinical trials, testing drugs, scientific interventions. If you don't use a randomized controlled trial, you can use a post-test only or under matched pairs designs. Though there are also types of randomized controlled trials. In the post-test only control group design, it is done when the pre-test is not possible, or that it might sensitize participants to the intervention. So in this we use this post-test only if the intervention you're going to apply, if sensitizing these people will affect the results you will get. You want to test a certain diet program. If you first test these people, that is what we looked at in internal validity, you will influence the results. So in some tests, you don't do the pre-test. You just give them the intervention, and the other one you don't do. Then after some time, you record the post-test, meaning you're going to compare your results with the standard known values. So you don't do the pre-test. That is the pre-test, the post-test only control group. Then the matched pair design. You first match the participants into pairs based on key variables. It can be age. Like you first get two pairs. maybe a man and a woman, or if it is age, a child and an adult, child and an adult, or it can be anything you are testing. You first group them into pairs. Then you randomize within each pair who will go to which which group, either intervention or control group. So this creates a perfect balance on the matching variables. And it is common matched pairs design ensures more perfect distribution of the confounding factors. For example, if you are testing a new farming technique, you know that there are factors that can affect what is the size of the farm. You're going to use farmers. You're going to give them this new farming technique. You can get two pairs so that the one who has a smaller size, you first put them in pairs which are similar. That those who have smaller sized farms, then those who have bigger farms, you give them two of them. Then maybe you get those who have soils which are more clay, or those plus those, then those you group them to then those with good soils, you give them to then you randomize. So it makes sure that every key factor has been distributed both in the controls and the groups, not making an experiment. You applied your farming technique, but what if you only gave it to people with good fertile soils and the results are due to the fertile soils? So you have to get those with fertile soils, you give them two pair, then you randomize who will go in which group. That is a matched pairs design. So those are also types of randomized controlled trials. But sometimes you can't randomize. That is when we use the quasi experiments, and they are more applicable in public health because not everything you are going to get the people and you randomize them to which group. Sometimes it is impossible, impractical, or unethical. It is impossible, impractical, and unethical to randomly assign people. An example can be that you want to test in Uganda, does giving lunch to primary schools, will it increase the attendance or the attendance or the enrollment of children in schools? Just doing randomization among which districts to give is unethical. It is not ethical because how can you randomize that now we are going to choose this district to give them food, this one will not? It is not ethical. Sometimes it is impractical or impossible. When you cannot randomize who will go to which group. Then that is when we use the quasi-experimental designs. So these ones, they include manipulation, but you don't do random assignment. You apply intervention, but you don't do random assignment, and they are very common in real world public health programs. And there are two types of the quasi-experiment designs. There is what they call the non-equivalent groups pre-test, post-test design, and this is the most frequently used. Here the groups are not equivalent. You already get the groups that are pre-existing. For example, if it is a non-government organization that is going to teach job skills in one parish, like you don't need to randomize which parish will be the control or not, but you may choose one parish, you apply those job skills, then the neighboring parish you don't apply those job skills. Like the groups are not, you didn't randomize, you simply selected the existing groups that the parishes are already there, or the villages. You just choose one village to be the intervention, then another one to be the control. That is when it's called non-equivalent. But if you don't do that, you can do the interrupted time series design, and this is very strong. It involves taking multiple measurements of the outcome before the intervention and multiple measurements after the intervention. The goal is to see if the intervention caused an interruption or a change in the trend. If you're applying your public health intervention. Okay, let's say you're going to put traffic lights in Gulu City. You first observe for some good time You first observe for some good time in the city before applying the city lights. You look at the crime rates, you look at everything, you make a trend. It is like a graph, that trend before the intervention. Then you apply the city lights in the intervention, like in that city. Then you don't put the city lights in another city. So you have simply selected cities without randomization. Then again you follow after some time to see how is the trend changing. If that is what we call interrupted time series. If there is a great change in the trend, then it means that our intervention is working. If the crime rates reduce and so on. So those are just study designs. So you can use any according to your research question, according to the practicality, the resources you need, and the gaps you need to fill. After you have got your study design, you have to decide what is the study population. You have got the design you need, you have got the research question, then you have to define the study population. Who are we going to study? You have to precisely define your study the population. You create clear inclusion criteria, that is the characteristics of people that must be in the study, and your exclusion criteria. If you have decided that you are going to measure to do a study on hypertension in Gulu, or does the feeding on a vegetarian diet reduce hypertension among the old aged in Gulu district, then you have to set the inclusion criteria. Who will be the participant? What do you depend to say that this one will be part of? This will be my study population. From your research question itself, you see that for someone to be part of your study population, they should be aged maybe 30 to 65 years, because you said maybe the age they are mature. Number two, they must be residents of Guri city for at least 1 year. Because you have said in Guri district, if you just get a random person migrating or traveling through Guru, they are not part of your study population. They have to be willing to provide consent. That can also be a criteria you will use. That you also have to have an exclusion criteria for your study population. For example, if someone is currently pregnant, if you are going to test a certain intervention, you say that if someone is pregnant, they will be excluded. If someone has been diagnosed with kidney disease, because these two conditions can cause hypertension. If someone is unable to speak English or Luo, it means most likely they are not even residents of Gulu district. So you have to state your criteria very well. Your inclusion exclusion criteria has to be like the entry rules of someone to be part of your study population. Research on health disparities. Much of public health research aims to identify and understand health disparities. So if you are to choose your study population, first research on the health disparities in that area you want to study. And the importance of this is being specific. It is not all about picking large samples, but when you research on the specificities and you get a specific study population, then you get better results. You first look at the health disparities in the area you want to study. The health disparities are preventable differences in the burden of disease, injury, or opportunities to achieve optimal health that are experienced socially by socially disadvantaged populations. So your research can shine a light on these inequalities, meaning in the area you want to study, first look at the health disparities in that area. You could compare the maternal mortality rates of people in Kampala, where they have more access to hospitals, and you compare with maternal mortality rates of women in Karamoja. So if you identify this disparity, is a first step towards advocating for more resources for women in Karamoja. Then number two, in identifying who you are going to study, you have to you have to you have to define precisely the group of people your research will focus on. For example, the people you're going to focus on is what you will call the study population. It is not about who you want to study, but creating a clear, specific definition that guides every subsequent step, especially the sampling process you will use. So instead of saying that your study population is people in Gulu, it is better you say that female border riders that are aged 18 to 30 years operating within Gulu city. That is more precise. So you have to be clear and specific. The importance of being precise is that it ensures that your findings are relevant and applicable to that specific group, because the more specific your population, the more applicable your research findings. If you have said that you focused on female border riders aged 18 to 30 years in Gulu City, the results of your research will apply to that specific group. But if your population is not specific, it is hard to generalize your findings. Number two, it allows other researchers to understand, replicate, or build on your work. Because your population was very specific, means your research is reproducible. Someone else can do the same exact research because they will use the same population you used, since it is precisely defined. Then what is most important, it is essential for selecting the right study design and the sampling strategy. You can't sample from a population you haven't defined. So whatever you are doing, whether you are studying malnutrition in public health among certain children in BD refugee settlement, their challenges are very different from the same types of children who are living in elite schools. Meaning, when your population is very specific, it prevents you even from mixing these groups. That my focus is on population of female border riders. The problems of females and males may be different. So you have to even specify that. So it determines your study design. Number three, you need to make a population specific research when you are defining. Like your research should be population specific, and that is what we have been stressing. That you have to focus on one particular group, because the population has a unique set of risks. Every population, they have unique behaviors, they have unique health outcomes that need to be understood in detail. So when you're describing your study population, you focus on one particular group. The goal is not to generalize to everyone, but you have to gain deep insights into the chosen group in order to create targeted interventions. Otherwise, if your research was ambiguous, it is even harder to make targeted policies because your study population was ambiguous. Still, to emphasize defining your study population, you have to understand that there is intersectionality. People don't live in neat little boxes. They have multiple identities that overlap. So what we call intersectionality is a framework for understanding how the overlapping identities create unique experiences of advantage or disadvantage. So that in public health, it means you have to recognize a person's health is shaped by the intersection of all their identities, not just one. So in your study population, you identify them. If you're in America and you study, you have dealt to Negroes who are males, maybe who are in a certain area, you have to be specific, because if you are not specific, research findings are different for different populations due to intersectionality, many factors. The health experience of a poor rural disabled woman is not just the sum of being poor, rural, or disabled, but all of these three things, the four factors, they create a unique experience for that person. Meaning, if I'm going to make a study, I will define a study population where I'm finding that on the rural disabled women, in Gulu or in this village, there your study population is better, and even your interventions can be better applied to that population, meaning the policies they will make will be for that targeted group. So still to amplify why it is good to look at intersectionality, it helps you to avoid simplistic conclusions. It will help you to reveal the hidden health disparities that might be missed if you only look at one factor at a time, instead of looking at prevalence of HIV in men and women. If you narrow it down, you will find disparities that actually rural women, there is a disparity between rural black women from the women living in cities who have money. So if your study population is focused, you discover other health disparities. It is more effective and equitable. Another consideration is that there is what they call in quotes the high risk population. When you're defining your study population, you have to take concern not to identify some people as high risk, because high risk is used to identify groups that need urgent intervention, urgent attention. You may talk of the elderly, the children, all those. You may say that people, high risk population, and you say that sex workers is a high risk population. But labeling them as such, there is a way to create stigma, blame the victim, and overlook the structural factors that may put these people in those situations. If you are looking at drug addicts, labeling them as high risk population can lead to stigma or can lead to resentment, because there are already those structural factors. It might be due to poverty or other unseen factors that are putting them in the condition they are in. So when you're defining a population, you don't need to use terms as that. So in conclusion about defining your study population, there are basically 5 tools you use. In your study population, mention their geographic area, that in a specific village, district, or region. Number two, mention the demographic, that in my population I'm dealing with men aged 18 to 30. You state their ethnicity, maybe the level of income or the occupation. You have to be specific in all of those. You can also describe your population using their health status based on specific disease conditions or based on their behavior. You can also, behavior based on specific action or behavior, like smokers, that you in your study population, you are you are going to interview active smokers or who do specific dietary habits. And number five, in your study population description, you talk about the social cultural based on belonging to a specific cultural group or social network. So often the best definitions combine multiple methods for maximum clarity. You combine all of them, that in my population I'm going to deal with adults who report consuming 3 or more bottles of beer every day. Or you combine that fishermen on Lake Victoria, you have said that demographic they are fishermen. The geographic you have said they are on Lake Victoria, who do not use life jackets, that is a behavior description. So it is better if you combine these tools when you are defining your study population. Once again, when you are choosing your population, you have to know the importance of research on women and children, because systematically or historically it is known that many times research is done without involving women or children. But you have to understand that they are cornerstone of public health, and they often face unique biological and social vulnerabilities. Their health is an indicator of the entire community's health and predicts the health of the next generation. Improving maternal and child health has massive ripple effects. So it is good if you make researches on women and children, because many times when interventions are made, an intervention that benefits a pregnant mother automatically benefits the children, the unborn baby. Automatically it will affect the next generation, because if it benefits the children, then the profits will go to the next generations. So however much they have unique social vulnerabilities, research on women and children has a massive ripple effect. So you need to research on things dealing with women. They have unique biological and social vulnerabilities, and that brings special considerations that you need to consider when you're making research on them. Number one is ethics, because women and children are regarded as vulnerable population in ethics. So you need you need extra safeguards, such as getting consent from parents if you're going to deal with children, and you have to ensure that you do no harm, because many times they are in positions where they are vulnerable. Their biology, you think of the pregnancy, childbirth, and child development. They involve unique biological processes. So if you're designing a certain intervention, you don't just assume that what will work for a man will also work for a woman. If you're researching on a new malaria drug, you must conduct specific studies on its safety for pregnant women, and you establish correct dosages for children of different weights, because they are regarded to be vulnerable because of their unique biological reasons. So you cannot just guess based on data from adult men. They also need to have specific risk studies done on them, things that will not apply to the men. And lastly, the social roles. Women's roles as caregivers can impact their ability to access health services or participate in research. So you have to also consider that since they're usually busy, you adjust your schedule to fit in their time schedule. So the key takeaways on who to research on. We said that defining your study population is a foundational step that will influence everything else. You have to be specific and precise and combine data about their geography, demography, their health and behavior while defining your study population. You have to be mindful of intersectionality and avoid stigmatizing labels like high risk. You focus on conditions that create risk. If you label sex workers or drug addicts as high risk, it is stigmatizing. And we said you have to be mindful of intersectionality, that many factors are involved to affect people's outcomes. If you're designing any intervention, choose a specific population. Lastly, I've said that women and children are vital to public health, but they require special ethical and scientific considerations. So now we go to the next part. When I say that we are looking at research as a continuous process, you have decided your study population. The next question will be, now how many people are you going to recruit? How do we actually select people from this population? So it takes us to the sampling techniques. How many people do you need to interview? How do we know the number of people we need? Those are the sampling techniques. Sampling is the process of selecting a subset of the population to participate in your study. The goal is to select a sample that is representative of the larger population, so your findings can be generalized. If you want to understand the health needs of people in Gulu, they might be over 150,000, and you can't survey anyone, so you have to pick out a subset that is representative, contains all the characteristics of the main population. So sampling is like you want to test soup in the whole saucepan, but you just pick out a spoon and you do tests on it, then you define the whole soup. There are mainly two types of sampling in research: probability and non-probability sampling. What we call probability sampling is any method where every person in the population has a known non-zero chance of being selected. That the people who are participating, they have a known chance of being selected. It requires a sampling frame. All probability sampling, you have to know the sampling frame. How many total people am I dealing with? What is the total number of people in my study population, so that you sample out. Number three, it allows for generalization. Since you have done a random sampling, they have equal chances of, but they have known chances. Probability sampling, not every probability sampling they have equal chances, but the chances have to be known or measurable. So, but if you go to non-probability sampling, the probability of being selected is not known. Number two, you base on convenience or the judgment of the researcher to determine who participates, and does not allow for safe generalization. And we realize that we mainly use non-probability sampling if we don't know the sampling frame. You don't know how many people are in yesterday population. You cannot access the whole of their data, then automatically you are left to non-probability sampling. Probability sampling, just to go through briefly. Simple random sampling, its hallmark is equal chance. Every person in simple random sampling should have equal chance of being selected. Whether you get the whole sampling frame, the list of the people, then you give them random numbers, you arrange them in ascending order, then you choose the first number of people you want. Everyone in that list, in that study population, has an equal chance of participating. That is when we call it simple random. For systematic sampling, you select every nth person from a list. I get a list of people from a clinic registrar. Then, depending on the number of people I need, I guess I'm going to choose every 10th person on the list. Then you're using systematic sampling. You can do stratified sampling. You divide the population into important subgroups. It might be by gender or district. Then you do a random sample in each subgroup. And this one ensures that your sample is representative. You go to the hospital, identify that different groups. Or if they are villages, you identify different groups. You group them according to certain criteria. Then you perform samples in each of those strata. But it is different from cluster sampling, because in cluster sampling, divide the population into clusters. It might be village. Then you do a random sample on that cluster. Every sample you have cluster you have picked, you interview every person in that cluster. So to do probability sampling, you have to know the sampling frame. Without it, you cannot do probability sampling, and it is better because it is easy to generalize your results, since most of the confounding factors are controlled for in the random sampling. And selection bias is eliminated in random sampling, but sometimes you have nothing to do when you don't have the sampling frame, or even if the sampling frame is available, there is a specific kind of people you need, that you feel these are the people who are qualified for my research, then you cannot do probability sampling. In convenience, select whoever is easiest to reach. That I will go to Google main market, and I will survey shoppers at the main market, since it is easy to access them. You are doing convenience, and it is prone to bias because you are the one who decides. Purposive is the same as judgment sampling. You look for those, you judge among the participants so that these ones fit, these ones have the specific characteristics I need. You go and you say, I'm going to interview only traditional healers to understand their perspective on mental illness. You have used purposive sampling so that traditional healers are the ones I need. Snowball sampling, you ask the initial participants to recommend other people who meet your study criteria. And it is useful for reaching hidden populations like drug users, sex workers. One sex worker takes you to the next sex worker. Sample size, when you're talking about how many There is a concept of sample size and representativeness. But you have to know that a representative sample is more powerful than a big sample. A small, well-chosen probability sample can be much more accurate than a large biased convenience sample. That if you go and you depend on convenience and you choose 1,000 participants, someone who chose fewer but representative samples will get more accurate results than the other one who used the biased convenience sample. For example, if you are doing a blood test uses a tiny representative sample of your blood. A large sample from just your finger would not represent your whole body. So someone who you get a small blood sample from small blood sample from elsewhere and you use it for tests. It is better than you focus on only one area. That I'm going to make results for prevalence or the average blood pressure of Ugandans. I'm going to use Wakiso district. Then you go and you interview everyone in Wakiso district. The results you'll get, even if you have used very many samples, it is not the same as someone who goes in various districts and you pick out samples so that you get a representative sample. So always aim first of all for representativeness. Even if the sample is bigger, bigger is not always better. How you choose is more important than how many you choose. Then the second last part, you have determined your sample. You have now, yes, I've got these are the 50 people I'm going to interview. Then you have to measure. How do you measure health? Because you have to make measurements from these samples. You give them the intervention, or this is the control, these are them I'm going to expose to, or it is an observational study. How do we do the measurements? Measurement is a process of assigning numerals to variables to represent quantities of characteristics. You assign numerals to variables in order to quantify them. So in public health, we often need to measure abstract concepts or constructs. What we call a construct is an idea or concept that cannot be directly observed. For example, knowledge, attitudes, stigma, social support, depression. These are things that we usually measure in public health. And most of them are constructs. They are not variables. They are not direct variables that can be measured using tools. So it means that we need to assign numerals to these variables so that to represent quantities. You cannot measure, you can't see stigma against people with HIV. So what you do, I can construct an interview with a series of questions and I use it as a scale. I may ask if I'm assessing stigma towards HIV, I may ask, would you be willing to buy vegetables from a vendor with HIV? Then I put values. Strongly agree 5. I may 3. I cannot. I put 1. So there I'm assigning numerals to variables in order to represent their quantities. So we measure constructs using multiple questions that are combined into a scale. That is for public health research. But in any research study you are doing, there are two pillars of good measurement. Whatever tool you are going to use, whether it is for this experiment you are going to measure blood pressure, or for the qualitative ones you are going to use a questionnaire, or you are going to use any tool you are going to use, it has to be reliable and valid. All these things are looked at in your research paper, in your research proposal. Does the tool that you want to use produce the same results if used again under the same conditions? For example, if you step on a weight scale 3 times in a row, does it give you the same reading? That means that the tool you're going to use is reliable. Otherwise, you may be using unreliable tools, then you get results out of chance. Number 2, it has to be valid, or what we call accurate. Does the tool actually measure what it is supposed to measure? If you are measuring the weight scale Does your weight scale show your true weight? So if it shows your true weight, then we say it is valid. So those are the hints we use. Reliability, it has to be consistent. Validity, accurate. And a good measure has to have both of them. Also in collection of data, you have to optimize the self-report data because you may use interviews or you're using surveys to collect data, and the person you are interviewing is the one who is going to report by themselves. They have these precise criteria that you have to follow. Number one, ask good questions because it will bias even what someone will reply. You have to be specific. Don't ask, do you exercise regularly? Such a question is harder to ask, but you ask in the last 7 days, on how many days did you do at least 30 minutes of moderate physical activity? Such a question is more specific and the results are higher to be relied upon. So if it's self-report data, whether they are interviews or surveys, questions have to be specific. Use simple language. Avoid jargon and complex terms. Avoid double-barreled questions. Don't ask two things at once. You ask, are you satisfied with your pay and working conditions? Someone may be satisfied with one and he's not with the other. Number four, you pre-test your questions before using them. These are the things you mention in your research proposal, how you will ensure that your data is valid and reliable. First, try out your questionnaire on a small group or your test tools on a small group to see if they are reliable or if they are valid. If you give your questionnaire, how many people filled all the questions, how many denied it, it can help you to optimize the self-report data and you avoid the bias that it can lead. So the clearer the questions, the clearer the answers. That is garbage in, garbage out. Then the last part, how do we do data management and analysis? You have all your data, you have collected it, now you want to analyze it. Remember, you already made a hypothesis at the start of the research that I want to identify this, I want to prove this. It is the data that has to talk about it. In the previous part, we talked about qualitative data analysis. And now we're going to look how do we do data management and analysis. That is from paperwork to power. We start with data management and cleaning. Even before you do an experiment, you have to organize, check, and prepare your data for analysis. Some of the questions we ask, why is it? The importance of data management is to ensure that your data is accurate and you prevent costly mistakes later. If your data is poorly recorded during the collection time, you didn't clean it, you didn't check for mistakes, chances are high that after collecting it, you will have to do that. You have to collect the data again and it can be costly. During the data cleaning, three things we check for. Check for the out of range values. You gave the people an interview or you were recording the age and there is somewhere you recorded 150. That is an out of range value. You have to check for it and you correct it. You look for implausible values which are not realistic. For example, if a man you give him a questionnaire and he recorded as being pregnant, you don't just go and you feed in the system. Then you monitor for any missingness to see if some questions were often skipped. That is what we do in data management. In data management and cleaning. So it is like even when you have already cooked your food, you have to data cleaning, you have to wash the vegetables before you cook. You are going to cook, not just get stuff and put in the saucepan. Describing your data. You also do it in data management. You have even before you do the tests for what the chi-squared, the z-test, the t-tests. First describe your data. Put some graphs. Calculate some measures of central tendency. Measure the variability of your data. First, describe it. So you have to summarize and describe the basic features of your data. You can measure mean, median, mode, or you measure the range, the standard deviation of your data, or you use charts, you do the histograms, the box plots, the pie charts, you describe your data. After describing it, then you go to the analysis, to the tests. And there are two tests depending on the type of data. We can do parametric tests or non-parametric tests. What we call parametric tests are the statistical tests that assume that your data follows a specific distribution, usually the normal distribution. That is when we talk of the Z tests, the T tests, the F tests. So they are used for continuous outcome variables. Most of the parametric tests like age, weight, blood pressure, we will not use Z test, T test for categorical data. Then you get the p-value, because most of those tests, whether you have used Z test, T test, or F test, it gives you the p-value, which tells you the probability that the result you are seeing is due to chance. And as always, a small p-value suggests that the result is statistically significant. So after you have cleaned the data, describe it, do the parametric test, that is if your data is continuous and follows a normal distribution. The tools we use, we can do the independent group t-tests in parametric analysis, or other t-tests or z-tests. For example, we can do a test: is the mean blood pressure of men different from the mean blood pressure of women? Since men and women are independent populations, I can use the independent groups t-test to see if there is a difference. That is, if I get the p-value when it is less, then I make a conclusion in comparison with the hypothesis or the research questions that I stated at the beginning. Parametric analysis, I can also do correlation tests. You measure is the strength and direction of the is used to measure strength and direction of linear relationship between two continuous variables. Either use Spearman correlation, then you test for correlation. Is there a relationship between number of hours and exam? So meaning if your research question was saying that is there a relationship between this and this, meaning at the end in your data analysis we expect you to make a correlation test to show that if there is, and you show even the strength of correlation using a correlation coefficient. You can also do regression in parametric analysis to predict a value of one variable based on the values of other variables. This one we use the values we have collected to predict another value either above or below. Those are regression tests. But the data may not be normal, or it might be categorical. That is when we use non-parametric tests like the chi-square. So non-parametric tests are used when your data does not meet the assumptions of parametric tests. They are often used for categorical outcomes like yes or no. Do you smoke or not? Did you get lung cancer? Then that is non-parametric. You cannot say that that is normal distribution or this. So you use non-parametric tests like chi-squares. And the chi-square is called the workhorse of categorical data because it is used, it is the most common non-parametric test, and we use it to determine if there is a significant association between two categorical variables. You recorded information, females and males. You recorded their education level. Then you want to say, is there a relationship between gender and the highest level of education? Then you get your chi-square. You do the test, you get the p-value. If it is less, you say there is a significant relationship. If not, you fail to reject the null hypothesis. So the type of data, it all starts from the research question to define all the rest. After you have done your analysis, Then you share your findings because you have to discuss. The analysis is done in the discussion. You do the discussion, the conclusions, the recommendations. You have to disseminate your findings because it is unethical to do an experiment on people and you don't share the findings. Like it is like the experiment was useless. So you manipulated the people. Dissemination ensures that your work can contribute to scientific knowledge and improve public health practice. The key dissemination channels: you may use peer-reviewed research articles, or you use conference presentations, or you make policy briefs before decision makers like Ministry of Health. You do community meetings to share the results with your participants. So it goes back with what we started with. The purpose of research in public health is to inform practice, not to make research and you keep it to yourself, then it becomes useless. When you are publishing your research, it is always ideal to make a research article or a research paper for publishing either in an online journal, and the format is you mainly use IMRAD. You start with the introduction because it is the research paper you are going to publish. Someone reading your research paper or research article, they will start with the introduction. Why did you do the study? What was the research question? You verify it. Then you go to the methods. They will want to know which methods did you use to answer your question, which designs, participations, which measures, how did you get the samples. Then you go to the part of your research. Which results did you get? Well, which results did you get? You state what you found. Then you do that discussion. What does it all mean? What is the interpretation? What limitations did you get? What conclusions? Then you publish your research article. So in brief, in all that we have looked at, we have seen that the whole process of research follows a circular model, and it has to end up with informing practice. So when you're disseminating your findings, particularly that discussion section, you have to identify limitations and you suggest future research. Like we said that you can get research questions from the discussion of other research papers. Also in your discussion, you have to make conclusions, you identify limitations, then you suggest future research. So this completes the continuous mode of public health research and practice. You have to disseminate your findings. So that is the summary of what we have looked at: how to frame a focus research question and research proposal, understanding research ethics and the role of the institutional review boards, how to choose appropriate study design according to your research question, how to define your study population, how to develop a sampling strategy, how to select or create reliable and valid measures, how to understand data analysis, and lastly, the structure of a scientific paper to share your findings. Thank you for watching. You may share, subscribe, and like the video.